Alright, so with the mind maps on disorders of growth and neoplasia, let's try and brainstorm whatever we remember. So we'll look at the definition, nomenclature, classification of neoplasms, like characteristics of neoplasms, whether benign, malignant neoplasms, and also the grading of malignant neoplasms. Alright, so developmental disorders nomenclature. When you talk about hypoplasia, it's an incomplete development or underdevelopment of an organ with decreased number of cells so that the organ fails to reach normal size. For example, renal hypoplasia will be bilateral. That's chronic renal failure in hypoplastic left heart syndrome. So another term too is agenesis or aplasia. That is a complete absence of an organ and its associated primordium, for example, kidney. So total bilateral agenesis is incompatible with life, and unilateral renal agenesis is compatible with life. Of course, the person can survive on one kidney. The opposite kidney enlarges by compensatory hypertrophy. And also with pancreatic agenesis, it's of course incompatible with life. Okay, what about hematoma? So hematoma has to do with excessive focal overgrowth of cells forming a mass of a mature specialized cells or tissues indigenous to the particular site or native to the organ in which it occurs. It's usually entirely benign. For example, lung may contain islands of cartilage, blood vessels, bronchial type structures, and also lymphoid tissues. Okay, so ectopia is out of place and outside. That's the meaning of ectopia. So congenital displacement of any organ or part of the body, like ectopic abdominal locations. Example, the kidney and the pancreas. Okay, so ectopia or ectopic collection of normal tissues could be termed as choristoma or heterotopia. Okay, so choristoma or heterotopia has to do with ectopic collection of the normal tissue. So adrenal cells and the kidney capsules, that's choristoma or heterotopia, and pancreatic tissue in the mucosa of the stomach too. Duodenum, jejunum, Meckel's diverticulum, and the ileum, and also endometrial tissue that can be found in the myometrium or elsewhere in the body, example the skin, the eye, the vulva, or any other place. That's like the type of ectopia, like choristoma or heterotopia. So dysplasia actually is a term that's used to describe disorderly but potentially reversible proliferation of cells, usually used in reference to epithelia. So it describes loss of certain uniformity with respect to the size and the shape, and loss of normal architectural orientation. So there is increased mitotic rate. Okay, that's one. Right, so let's define neoplasia. So there are several ways of defining it. So let's use the Willis definition. Neoplasia is an abnormal mass of tissue growth of which exceeds and is uncoordinated with that of the normal tissues, and which persists in the same excessive manner after cessation of the stimulus, which has involved the change. People's definition, that one, neoplasia is a tumor. A tumor is a heritable, altered, relatively autonomous growth of tissue. And yeah, so basically, when you talk about neoplasia, it has to do with tumors, or yeah, abnormal mass of the tissue. But then tumors are just purposeless growth of tissue that tend to be atypical, autonomous, and aggressive, or persistent growth of abnormal tissues. And then neoplasia, neo means new, plasia, growth, tumor means swelling, cancer is from the word crab, common term for malignant tumors. Okay, so like the spider web lesions in liver or adrenal gland or kidney. Okay, so tumors have two components, the parenchyma and the stroma. So the parenchyma, there's a mass of neoplastic cells, and the stroma, connective tissues, and blood vessels. So the nomenclature of tumors is based on the parenchymal component, which is the mass of neoplastic cells, not just the connective tissue and blood vessels. So more on the nomenclature of tumors. The name of the tumor has two parts, a prefix and a suffix. So the prefix, presumed cell of origin, and the suffix, like OMA for all tumors. So exceptions are granulomas and tuberculomas. Okay, yeah. So granuloma is not a tumor, tuberculoma too is not a tumor. Okay. And granulomas are activated macrophages, tuberculoma that is formed in Cox disease. Okay, so benign neoplasms have only the suffix OMA that is added to the prefix, usually the cell of origin. So mesenchymal tumors follow this simple rule. For example, lipoma, fibroma, chondroma, osteoma, leiomyoma, rhabdomyoma. And note that there are some exceptions. For example, melanoma, seminoma, lymphoma, hepatoma. Yes, so all these are not just benign tumors but actually malignant. Yes, so benign tumors, lipoma, fibroma, chondroma, osteoma, smooth muscles, lymphomas in the cardiac mass. Okay, so melanoma, skin cancer, hepatocellular carcinoma, hematoma, lymphoma, and seminoma, the testes. So those ones are malignant and exceptions from the benign neoplasms. Epithelial tumors are divided into adenomas from glandular cells or forming glands, and papilloma or papillomas arising from surface epithelium and forming finger-like or warty projections. So in addition, the macro and micro appearances are added. For example, cystadenomas, they form large cyst follicular adenomas too, and this forms follicles, papillary cystadenoma, forming finger-like projections in epithelium of the cyst. So malignant neoplasms for mesenchymal or connective tissue tumors, the suffix modified to sarcoma, and for epithelial tumors or of any of the three germ layers, the suffix is carcinoma. So sarcoma for connective or mesenchymal tumors, and the epithelial tumors, carcinoma. So carcinoma for surface epithelial tissues, and adenocarcinoma for glandular epithelial tissues. Some tumors arise from more than one cell type, from one germ layer, and are called mixed tumors. For example, mixed tumors of salivary glands. Um, Another example, pleomorphic adenoma, fibroadenoma of the breast. The tumors that arise from pluripotent cells in the gonad and differentiate along um, more than one germ layer are called teratogenous tumors and may have smooth um, skin, tooth, even muscle fat, gut epithelium, brain. Yeah, and these may be benign teratomas or malignant teratocarcinomas. Okay, so the morphological pattern of tumor growth, you have the sessile, polypoid, and papillary growth patterns. They're usually associated with benign tumors. Okay, so, but for malignant tumors, you have a fungating, ulcerative, annular growth patterns, and are usually associated with malignant tumors. So the polypoid, we also call the pedunculated polyps too. The papillary like fingers, fungating, like that of moles, like round, big, and ulcerating, annular too for malignant tumors. So sessile, polypoid or pedunculated, and papillary for benign tumors, and fungating, ulcerating, annular growth for malignant tumors. Okay, so with classification of neoplasia, like I said earlier on, we have clinically by behavior, whether it's benign or malignant, and histologically by histogenesis. That has to do with the tissue of origin or a combination. Okay, so behavior, whether benign or malignant, benign has a good prognosis. So the tumor grows at the site of origin and does not spread or invade nearby tissues, and it will generally not kill except when situated in a vital area, and may cause clinical problems by pressure, obstruction, and production of hormone, and rarely by transformation into a malignant tumor. So malignant tumors, they have poor prognosis, and the tumor will grow and spread into nearby tissues and to distant sites and eventually kill the patient. So the primary is the original tumor, and the secondary is the metastatic tumor from another site. So we have histogenesis, and by tissue of origin, have the epithelial, both covering and protective epithelium and compact secreting epithelium, and the mesenchymal has to do with fibrous tissue, bone, and skeletal tissues. Okay, so with the classification of tumors, let's take them one by one. The tissue of origin, we look at the behavior, whether benign, intermediate, or malignant. So with the epithelium, the first one we'll look at is the covering and protective epithelium, like squamous epithelium. So squamous epithelium, the behavior, the benign behavior is squamous, like an example is squamous cell papilloma, and intermediate is basal cell carcinoma. For malignant is squamous cell carcinoma. Yes, but remember the benign is squamous cell papilloma. The intermediate is the basal cell carcinoma. So with transitional epithelium, the house transitional cell papilloma, and the malignant is the transitional cell carcinoma. And for adenoma, which is benign, that's columnar epithelium. Adenoma is benign, and the malignant form is the adenocarcinoma. So the compact secreted epithelium, adenoma, if cystic, that's cystic adenoma. If papillary, or it could even be papillary cystic adenoma, normal adenomas. So the cancer form is the adenocarcinoma or cyst adenocarcinoma, and the adenomas, of course, carcinoma, adenocarcinoma, or oat cell carcinoma, and the intermediate is the carcinoid tumor. All right, so um, that's for compact secreting epithelium, and the diffuse endocrine system. That's where you still have the adenomas and the adenocarcinomas too, like the oat cell carcinoma. For connective tissues, fibrous tissue, benign is fibroma, malignant is fibrosarcoma. Undifferentiated mesenchyme, the benign is benign fibrous histiocytoma, and the malignant is malignant fibrous histiocytoma, and the intermediate is actually atypical fibroxanthoma. Okay, so for fat, still dealing with the connective tissues, the benign is lipoma and the malignant is liposarcoma. For smooth muscle, benign is leiomyoma, malignant is leiomyosarcoma. For striated muscles, whether cardiac or skeletal, the benign is rhabdomyoma and the malignant is rhabdomyosarcoma. And synovium, you have the synovioma and malignant synovioma. And for cartilage, you have chondrioma and chondrosarcoma. For bone, it's osteoma for benign and then osteosarcoma. But the intermediate is giant cell tumor. And for mesothelioma and mesothelium, you have the benign mesothelioma and malignant mesothelioma. Blood vessels and lymphatics, you have the hemangioma and lymphangioma, and also with the malignant form is the angiosarcoma or corpusclarcoma, and meninges, meningioma, malignant form malignant meningioma, and with a specialized connective tissue like neuroglia and ependyma, we have the benign being astrocytoma or oligodendroglioma, but the malignant form is ependyoma. And that's for neuroglia and ependyma. For chromaffin tissue, the benign is carotid body tumor and the malignant is malignant carotid body tumor. And for lymphoid hematopoietic tissue, we have pseudo-lymphoma, for example in the rectum and the skin. And the malignant form is the malignant lymphoma, including Hodgkin's lymphoma, or Hodgkin's disease, multiple myeloma, leukemias, malignant melanoma, and then the intermediate is myeloproliferative disorders. The fetal trophoblastic conditions, the benign is hydatidiform mole and the malignant is choriocarcinoma, but the intermediate is chorioadenoma destruens, that's the invasive mole. And when you take germ cells, the malignant forms are semioma or this germinoma or malignant teratoma. The benign is just benign teratoma for totipotent cells, embryonic tissue, pluripotent cells too. But for the kidney, the malignant is nephroblastoma and the liver is hepatoblastoma. unipotential cells or unipotent cells, retinoblastoma, which is malignant, and hindbrain of the medulloblastoma, sympathetic ganglia, ganglioneurons in neuroblastoma too, and adrenal medulla. For pelvic organs, we have the rhabdomyosarcoma, sarcoma potiorioides. Okay, so for the embryonic vestiges, the notochord, chordoma, but for enamel organs, we have the intermediates being ameloblastoma. For parapituitary residues, we have the craniopharyngioma and the branchial cyst. We have the branchiogenic carcinoma. It has to do with the pharyngeal apparatus. For hematoma, we are dealing with malignant melanomas for melanotic tissues, and exostosis and achondrosis. The malignant form is the chondrosarcoma. The neurofibrosarcoma for neurofibromatosis, but the benign form is neurofibroma. And for tuberous sclerosis, benign form being glioma and malignant glioma. So characteristics of benign and malignant neoplasms, we have morphologic criteria, and this is used to differentiate the benign and malignant neoplasms based on the macroscopic and the microscopic appearances, and their clinical behavior can be predicted. So that is when you have your differentiation, rate of growth and growth features, mode of growth, invasion, local invasion, and metastasis. For differentiation, the extent with the parenchymal cells of the tumor resemble comparable normal cells, both morphologically and functionally, and well-differentiated tumors, moderately differentiated tumors, poorly differentiated tumors, undifferentiated or anaplastic tumors. So generally, benign tumors are by definition well differentiated, and cells may be so closely resemble the normal cells that at high power the neoplastic nature in neoplasm becomes inapparent. For example, in leiomyoma. So malignant tumors range from well differentiated to poorly differentiated ones, and a malignant tumor composed of undifferentiated cells is anaplastic. So undifferentiated tumors have cells that proliferate without maturation and so look like the stem cells, and a well differentiated tumor has cells that mature as they proliferate. So morphologic features used to indicate the level of differentiation, as micro, we have the polymorphism and abnormal nuclear morphology. The variation in size and shapes of the cells, that's the polymorphism. The nuclei and nucleoli may show polymorphism. For abnormal nuclear morphology, hyperchromasia, that is nuclear stained intensely with methoxylin, and this is due to abundant DNA. And also, with the morphology, high nuclear cytoplasmic ratio, as the NC ratio too. So the nuclei are disproportionately large for the cell size. A normal nuclear cytoplasmic ratio is 1:4 to 1:6, but in neoplasms it's approximately 1:1. So the nucleoli may be large, predominant, and there may be multiple nucleoli, and the chromatin distribution may be concentrated at the nuclear membrane. Angulated areas in nuclear membrane giving angulated nuclear shapes. Mitotic figures. Generally, the number of mitosis increases as the differentiation decreases. The malignant neoplasms, we have mitosis. Malignant neoplasms are more than mitosis than the benign ones, and with the undifferentiated tumors, they are more than well differentiated ones. The presence of mitosis does not mean the lesion is a neoplasm, though since the neoplastic lesion may contain numerous mitoses. For example, the bone marrow hyperplasias and abnormal mitoses are indicative of malignancy. These are tripolar, quadrupolar, or multipolar spindle mitosis. So the tumor giant cells, well, they are large cells, nuclei with features of malignancy, whether pleomorphic, hyperchromatic, high NC ratio. The NC ratio over being the nucleoside to plasmid ratio. And they may have single, double nuclear, like in Hodgkin's disease, or even multi-nucleated in sarcomas. So the orientation of cells, we have the loss of polarity, like anaplastic tumors, which grows as seeds, or large masses in a disorganized fashion. The stroma is usually scanty. So functional differentiation, benign tumors and well differentiated malignant tumors of endocrine glands, elaborate tumors of the cell of origin. So squamous cell carcinomas produce keratin, and hepatocellular carcinomas produce bile. So such functional differentiation is used to predict the behavior. A well-differentiated squamous carcinoma will show a lot of keratin formation. Some tumors elaborate fetal antigens not produced by the adult cells, and many of these antigens are useful in diagnosis or follow-up of patients. For example, the alpha fetoprotein in hepatocellular carcinoma and embryonal carcinoma, GIT, and also pancreatic tumors. Some non-endocrine tumors may also elaborate hormones. For example, bronchogenic carcinoma may produce ACTH as adrenocorticotropic hormone, antidiuretic hormone, parathyroid hormone, like so parathyroid hormone like hormones and insulin. As with the grading of malignant neoplasms, of the histological and cytological gradings, and they are subjective, so the grading reflects cellular characteristics. The grade of tumor does not always reflect the degree of aggressiveness. This is useful guide though. So it's determined or is based on the degree of differentiation of the neoplastic cells. So low grade neoplasms represents, for example, the tissue of origin with the evidence of slow growth, and high grade neoplasms tend to be anaplastic, evidence of rapid growth. So evidence of rapid or abnormal growth is provided by large numbers of mitosis, atypical mitosis, and also nuclear and cellular pleomorphism, abnormal nuclear morphology in high NC ratio, and also irregular or hyperchromatic nuclei in large nuclei, Alright, so with the grading, you look at the presence of the tumor giant cells, loss of polarity, necrosis, and also hemorrhage. So one thing that you could take off is the features of an neoplasia. You can see in some of the slides. So whether presence of mitotic figures or these other features, whether it's poorly differentiated too, can help you identify it's. So with the grading of malignant neoplasms, we have grade 1, grade 2, grade 3, grade 4. Grade 1 being well differentiated, grade 2 moderately differentiated, grade 3 poorly differentiated, and grade 4 is nearly anaplastic. Okay. So with high grade urothelial carcinoma, you see that it will fall probably and 3 or 4, but low grade urothelial carcinoma probably 1 or 2. Okay, that's anaplastic carcinoma and mitotic figures and the rest. So this is more of a summary of the introduction to neoplasms.